Underwent transtracheal, transbronchial.
Hi, good afternoon. I'm Adriana Branda from Buenos Aires, Argentina. I work for the hospital Francisco Muñiz from the city of Buenos Aires. And our group is now presenting a short work, well, it's long-standing, but it's for a method with low cost, but nonetheless a high diagnostic yield. We present a cohort of 435 patients who underwent either transtracheal or transbronchial needle aspiration with Schieppati rigid needle. This reusable rigid needle was created in 1949 by Argentinian surgeon Eduardo Schieppati as an alternative for diagnosing the mediastinum and lesions adjacent to the central airways. Though it was rapidly and gradually replaced by more modern, flexibly, and then US-guided technologies that are now the golden standard for studying the mediastinum, this tool remains an affordable tool in many developing economies. And we kind of, well, I didn't, I'm too young, but our head of department, Dr. Roberto Dure, took it out of the museum during one of our country's economical crises as a method to keep studying patients and not letting them out of treatment. So, shortly, this is a retrospective cohort which started in 2010 and it goes up to the end of 2021. They were all adults. They had mediastinal loads or pulmonary lesions around 2 centimeters, though we punctured some that were smaller. They were accessible via the central airways through rigid bronchoscopy, and we planned the site of puncture through CT scans and carefully measuring through structures such as the main carina. It was performed under conscious sedation and spontaneous ventilation, and at least 3 samples were collected for each procedure. It's 2 centimeters and it's 14 gauge. We have another measures, but this is the one that we mainly use. Oh, sorry. So, of these patients, mostly were men. The median age was 58 years, and they were referred to us to obtain diagnosis. More than half of them was for a mediastinal lymphadenopathy of mass as the main issue to be diagnosed. An extra 35% presented with solely a pulmonary mass on a first evaluation, and a 7% with a combination of both type of lesions. As of puncture sites choice, the station 7 from the 1 lymph node map was by far the most puncture site, followed by the station 4, then the helio nodes, and in a much smaller proportion, tumors adjacent to the central airways or central masses. And as you can see in the photos below, we can achieve samples with a size that enables to perform not only cytological but also histological pathology, and they were therefore used also for markers, biomarkers. With this technique, we achieved around 85% representative samples. It is a blind technique with an overall diagnostic yield of at least 79%, which is not bad for a blind technique. By far the most found diagnosis was lung cancer, mostly adenocarcinoma, followed by TB, which is quite representative of our country. Then other cancers, sarcoidosis, or other infections that could affect the mediastinal nodes. The complications rates were around 8%, and they accounted mostly for mild bleeding, which we could control with rigid bronchoscopy. So, in conclusion, in trained hands, this is a safe and cost-effective method that enables us to diagnose mediastinal or central pulmonary lesions. And as a data of color, we found no correlation between the absence of a visible airway alteration during regular bronchoscopy and achieving a sample of good quality or even a diagnose through the punctures. So therefore we can conclude that this is a valid, very valid alternative where disposable or US guided technologies are not available, such is the case in our unit and in most of the Argentinian public health system. And so it's a possibility that we have to offer our patients who are sometimes at the margins of modern technologies, but they're still worth our efforts. And for that, we thank our head of department, who is always like searching new alternatives. Thank you very much.
Thank you very much. Thank you for remembering Eduardo Schieppati, that I always mention in my talk, because it was the first that performed TBNA and is a pioneer, and probably the name is Italian origin, because Schieppati is an Italian name, so this is nice. My question is, what are the sites of the lymph node that are punctured with such large needle? Because I know that conventional TBNA is influenced in the results from the sites of the lymph node. You have good sensitivity for lymph node greater than 2 centimeters, and then the sensitivity is going down for smaller lymph node. Using such kind of needle, this 14 gauge is a very large needle. What is the limit sites of lymph node that you are going to puncture?
That is a good question. As I stated, most of the patients who underwent this method had lymph nodes of around 2 centimeters, but with punctures, nodes that were smaller. And we achieved that point through carefully measuring CT scans, doing a 3D reconstruction of the airway and choosing the best point where we can access that, and then marking how deep and in which angle we should do the transtracheal mostly. I don't know if that answers your question. They're mostly around 2 centimeters, but we've done it with much smaller nodes.
You avoided the 4L station. I see that you didn't function with 4L.
They were mostly 4R, but there were a few 4L, yes.
There is also a possibility to biopsy 4L with curved rigid needle.
Yes.
I still use a rigid needle and rigid bronchoscopy and rigid needle transbronchial needle aspiration, and there are straight needles. You can do the biopsy in the most locations, and the curved needle is good for 4R and even 4L. But if you point the bronchoscope right. And I have one question. Rigid bronchoscopy in cautious sedation. Are you doing this because we are doing rigid bronchoscopy in general anesthesia most of the time?
We usually use a small dose of fentanyl and midazolam, and then like a tiny touch of propofol. But it's kind of, it depends on where you read it. It's neurolip to analgesia or conscious sedation. It depends on the amount of it that you use. Sometimes, not many times, but we've used without propofol if the patient was too weak or too old. And we also use nerve blockage.
How are the patient experiences after the procedure?
Very good.
Very good.
Yes, we have more discomfort with patients that undergo, for example, dilation after benign tracheal stenosis than with these methods. And yes, we usually combine Dumont and Chevalier-Jackson to make the transition to bigger tubes a little easier.
Argentinian people prefer Gando.